Thank you so much for doing this.
Yeah, I'm Aws Almufleh. I'm one of the cardiologists here at Queen's. I joined Queen's after I finished heart transplant and heart failure training in Boston at Harvard Medical School. Before that, I did cardiology training in Ottawa and internal medicine training at McGill. And now in between, I also did echocardiography training. So this is my job now, is half echocardiography, reading echocardiograms, doing transesophageal echocardiograms, TEs, and the other half is I'm the physician lead of the heart function clinic here at Queen's.
So you've been around everywhere. And you did training, correct me if I'm wrong, in Saudi Arabia, Canada, and the States.
Right.
What's your favorite?
I'll give you the answer I give here, not the one in the States. But no, I really enjoyed getting to know the practice in every center and learn, what each center does best. And then, you build your own algorithm, your own practice pattern. So I enjoyed really having that exposure to, higher volume settings like Boston, for example, higher volume, much higher resources too. And then, a bit of lower resources, lower volume here. And you try to, see what you need to do for the patient.
I was telling you offline that Dr. Baranchuk, another prominent cardiologist, I spoke with him, and it's just so eye-opening to see so many people of such expertise, being so generous with their time, their knowledge, and just trying to teach everyone. And he literally said there's an up-and-coming cardiologist that's going to change everything, and is so intelligent and innovative. So, we can measure it's astounding. And just your work in the pre-hospital setting too, to try to fix the system issues of heart failure.
Thank you. When I shout out to Adrian, very, very skilled cardiologist and also a respected mentor in the field to me and many of my other colleagues. And I am passionate about moving care out of the hospital and into. There's not one patient that will fight you to get admitted, right? They don't want that. They want to be treated at their homes, and if not, then at least in clinic. Nobody wants to get admitted. But then all the resources, like you look at the healthcare funding, we don't have stats for Canada. For the States, almost 70% heart failure care funding is for hospital care. And so, if that is the case, if that's your paradigm, then patients will just decompensate until they go to the hospital. That's when they get all the cool stuff and the mechanical support devices and all the expensive medications. But if that is the case, many of them may not show up to the hospital, right? Many of them may not show up to the hospital. And so that's where you need to move the care upstate. Go to patients where they are, look after them in their communities and start to work with your community partners. So here, and I think we'll talk about it later, our work with the community paramedics and home and community care, and now they're Ontario Health at Home, where you try to provide that education to the healthcare providers to identify heart failure patients and refer them early.
So that's interesting. Is there any country or jurisdiction around the world that's doing this as effectively as you can, to keep them out of the hospital? Because correct me if I'm wrong, you go to the hospital, you've already decompensated. And the mortality rate's 1 and 2, right?
Yeah. This is a good point. This is a very good point. I want to emphasize that it is that being diagnosed in the hospital or in the emergency department is associated with worse long-term outcomes. And this is long-term outcomes. So actually, this is work we did here using, by funding from Queen's, the Time Institute and ICES, where we looked at heart failure patients in Ontario from 2012 all the way to 2022. And we saw, we wanted to compare those that get diagnosed with heart failure in the community, outpatient setting, versus those that are diagnosed in acute care setting or the emergency department. And the risk of death or heart failure hospitalization within 1 year, within 3 years, and within 10 years after diagnosis is 1.8 times higher if you're diagnosed in acute care setting. So that risk did not equalize after a few years, because you would think, well, there's a setback. They're diagnosed in the hospital. Maybe they get optimized better because we look after them in the hospital, or the resources are in the hospital. by 3 years, the risk shouldn't be the same. Maybe by 5 years, even up to 10 years, their outcomes are worse, right? So there's no question that you really need to move care out of the hospital and into the community. Now, your other question is, well, what country did it better, right? Where can we learn from? I'm still looking because in that same study, we found that 37% of heart failure patients, 37% of heart failure patients in Ontario are diagnosed in acute care setting. That's pretty good. When you look at the UK, for example, published about 50%, Alberta about 50%. So it's not like our outcomes are not too bad, but I think there's room for improvement, right? Not one patient would like to say, oh yeah, wait until I go to babies 4 and get diagnosed there. Share one bedded room, like 4 bedded room with for others. And no, people want to make the diagnosis at home and initiate treatment at the community.
What's been your experience with it all in heart failure and community paramedicine? Yeah, so we definitely had a good cohort of patients during our community practice that had pretty advanced heart failure. Mm-hmm. And one of the biggest things to manage with them was just they continued had to be readmitted in hospital, right? So, every few months we would meet them in the hospital and see, okay, what happens this time, right? Mm-hmm. And we were trying, I think we got better at catching it earlier. And one of the big things we did with that was just weighing people, once a week, and then using those sudden weight gain as a trigger to potentially increase someone's diuretic for a little bit of time and things like that.
Yeah.
What was really good was, being able to bring some diagnostic modalities upstream, like you said. So being able to do an electrolyte panel before starting diuretics, things like that.
Yeah.
But I guess, what do you think is the most high return on investment role for community paramedics to try to bring that, early diagnosis, early management upstream?
Yeah, community paramedicine. I'll be honest with you. Up to about 2 years ago, I didn't know what that was. Honestly, not at all. What do you mean? Paramedics who doesn't drive an ambulance and doesn't take patients to the hospital? No, this is a different paramedic who looks after, whose mandate is to treat patients at their home. And this was fascinating to me. But my mandate is the same too. Let's talk to those people. And so we go to the Frontenac paramedic, and also we met with the Lennox and Addington paramedics, Paul Osborne and Michael V here in Frontenac, and we said, okay, what do you have? What do you offer? And actually, they have a lot of resources, a lot of support. They get to know their patients. They go to their home. They have roster. How family doctors have roster. They have roster. This is my rosters of patients. I go and check on them. What do you do for heart failure? Well, we don't really do anything for heart failure, but now they will. So now Michael and his crew are coming to our heart function clinic to learn how to assess patients with heart failure, how to examine them, assess their JVP, and then diagnostics that you mentioned. So they don't have it yet, but we're looking into getting point of care blood testing. Right. Point of care blood testing. Imagine, you auscultate the patient, you're not sure your heart crackles or not. Are they volume overloaded or not? You try to look at their JVP. It's not always easy, right? You do a pinprick, you get your point of care BNP, brain natriuretic peptide, and there it is. It's positive. The patient has heart failure. Now we can initiate treatment. So rather than have 2 trips where you go, you do the labs, you come back to KGH, the lab is busy, we give you the answer next day, you can get it right at the bedside. And some other paramedics are starting to experiment with point of care ultrasound. Obviously, there are considerations to maintain the skill and for proper training, but I think the potential is endless. This is quite exciting.
Can you tell us a little bit more about that point of care BNP and what kind of threshold are you looking for? And then maybe what would be the typical treatment follow-up in the community for it?
Yeah, good question. So BNP is the brain natriuretic peptide. And in cardiology, we like acronyms. It makes us feel special. Nobody can understand what we say. But you have to remind yourself that, other people that have a lot of experience in many other fields, maybe they do not know. So I have to say. So BNP is brain natriuretic peptide. So this molecule is released from the myocardium. So the myocardial cells, in response to stretch. So patients that have heart failure, preserved or reduced ejection fraction, so weak or stiff heart, they develop wall stress, and then they release BNP. And it's a protective hormone because it helps you vasodilate you and helps you cleave excess sodium. That's a natriuretic part. It's also a powerful diagnostic tool. Where if you detect it in the bloodstream, if you are looking at BNP, and you're in the community, then we use 50 as a cutoff. If you are using anti-BNP, that's another related molecule, then you use 125. And it is quite a powerful diagnostic tool. It's available since the early 2000s, but in Ontario in November of 2021, it became publicly funded to be done in the community. Before that, our patients had to pay $80. And, most heart failure patients, many of them are older, they're retirees, some limited income, they're not keen to be paying, $80. So Dr. Almufleh looks at their BNP, that's all right. And so since the public funding for BNP, we've been actually quite regular consumers of that test, and I find it quite useful. There is other reasons why the BNP can be elevated. It is inadvisable to react on that alone rather than you do their full assessment. So in my in our hands at this point, the goal is to have it available when we are assessing a patient that we know in the community. Some of our patients are in their 90s. They want to be getting out, taking their walkers, going to life labs, doing blood work, and then going back home, and they come to us the next day. One of your colleagues goes there to their home and draw their blood work, or even better, does a point of care. So that has been the use that we're using so far.
So let's say their BNP is elevated, diagnosable for heart failure. How do we treat them now?
Very nice. Very good. So when you have, so remember what we said about the BNP, the brain natriuretic peptide, being released in response to wall stress. Now, wall stress doesn't mean that the heart is weak. Sometimes it's from heart stiffness. So the way I explain heart failure to my patients, I say, there are two types of heart failure. Either your heart is weak or your heart is stiff. If the heart is weak or stiff, then it's not able to accommodate all the blood that it receives from the legs and from other organs. So I say, imagine, you're trying to inflate air into a stiff balloon, or inflate air into a very full balloon. Air is not going to go in there, right? Blood has to go somewhere, so it backs into the lungs, fills them with water, and people get short of breath. Sometimes backs into their legs, fills them with water, and they have swelling in their legs. Sometimes goes to the belly, pushes in the abdominal organs, you lose your appetite. So when we say congestive heart failure, that's what we mean. Weakness in the heart or stiffness in the heart that causes accumulation of fluid in the body. And it's important to explain that to patients because it is a lifelong diagnosis, and the treatment is also lifelong. And then you will be surprised, you will be amazed by how many patients that have had low EF, low ejection fraction for a very long time, and they don't know they have heart failure. So when you explain that to them, what do you mean I have heart failure? Yes, it's because of this, but not to be discouraged. There are treatments that we can provide to improve your outcomes. So depending on what kind of heart failure the patient has, whether it is the weakness in the heart, and that we call the heart failure with reduced ejection fraction, or whether they have the stiffness in their heart, that the heart failure with preserved ejection fraction, then there are specific medications that we introduce to those patients that can improve their survival, their quality of life, and reduce the risk of heart failure hospitalization. And that's most people what really would care about. I want to be admitted. I don't care what you do with me. I do not want to go to the AWC. And then I don't blame them, right? It's a tough environment, especially when you have surge in bed capacity, and you try your best to try to help everyone, but it's a difficult time for patients in the hospital.
I was thinking, do you find it problematic to communicate with this terminology to patients? It's like, you got heart failure, so right away it's like, oh, I'm dying. Like, what does this mean? No, let me explain it, because there's categories of heart failure.
Okay.
So you have a low ejection fraction, or you have a preserved ejection fraction, or you have like mildly reduced ejection.
About that.
So how do you untangle all that?
Yeah, and I think the key is knowing your patient. The key is knowing your patient. When I was in training, as soon as I read about the patient and I get to know what's their background, I go in the clinic and I start explaining. But now, no, you go in the clinic and you ask questions. All right, you ask questions, you examine the patient, and while you're doing that, while you're collecting that data, you're also building an assessment of how much they know about their heart condition, and how much they want to know, right? And how much they want to know. And sometimes, for some of my patients, I don't explain all of this in one setting because it's overwhelming. And of course, luckily we have the support. We work in a team with the nurse practitioners at the heart function clinic, so we have the capacity to bring the patient back. Some family doctors who see patients, they barely have 15-20 minutes with them, and then now they have more patients. So I feel for my colleagues. But to answer your question, I really do not explain. I try not to explain any more than what I think the patient will be able to follow, and I provide resources and reading materials for them to keep the conversation, right? Some questions they want to ask, they probably thought of asking, they forgot, or maybe they didn't feel comfortable. It's in that written source, so they can read it at their own leisure. And then when they come back, see me or one of my colleagues, then they can continue the conversation. And it's a big, but when you think about it, most patients spend less than 2% of their lives, in healthcare, like in our clinics and hospital. Less than 2%, right? And in that 2%, you're trying to convince them to change the 98% of their lives, right? They like take these medications every day. What do you mean? I never took any medication. Now you give me 4? Yes, and maybe a few others. How is that possible? All right. So these 2%, we really have to use it wisely, and education's key. Education's key. Mm-hmm. So they are difficult concepts, but I think if you go gradually, teach the patient how the more important stuff, right? The more important stuff, because sometimes when they see me the first visit, they have severe volume overload. The GMP at their ears, they are very short of breath. They barely get up and just to go to the examining table. Here, I need to explain to them why they have that fluid in their lungs and what am I going to do to make them feel better. The next visit is, well, what can I do to improve your survival? Yeah, you're talking about your granddaughter and wanting to see her graduate. Let's see how we can make that happen, right? And so every patient has different things that they care about, and you need to reinforce that.
So what I hear you saying is that this is hard. Like the medicine's easy, but planning the communication, it's very patient-centered because one, I gotta know your health literacy.
Right.
How do I break this down to where you're at? And also, I like that human side is like, if that's your goal to go to your family member's graduation, it's like, how do I make that happen and explain it to you that makes them motivated enough to stay with the treatment plan?
Exactly.
Because, correct me if I'm wrong, only like 30% of patients actually meet the standard targeted therapies for the drugs.
Sadly, that is true. And this is Canadian stats, right? You'll say, oh, maybe that's the US. They have a terrible system, right? We're better. But no, this is Canadian stats, right? And so the problem with heart failure is that you can't treat it with one medication. And when the patient comes in and I want to start another one, he says, okay, yeah, what are you going to take off of my list so that I can take this one? No, I give you both. Right? Because they work together and they improve your outcomes. And so as you can imagine, it takes about 6 months to build up all of these medications. Mm-hmm. And then some of these medications, you start at a low dose and then you build it up. So if you really look at all the patients that are on the full doses, then that's about 30%. And that's a problem because we know that if you diagnose a heart failure patient, let's say at the age of 55, and you institute all of these treatments at the right doses, their survival improved to compared to a patient who's only on 2 medications. So not on nothing, on only 2 medications, the survival of the one in 4 with full doses is 8 years more. Think about that. 8 years more. Think about how much you're doing for the economy, you're doing for for their family, for the quality of life, right? But they have to be on all of these medications. So it is a difficult process to institute, and it's also a partnership, which is, and I think we could talk about that later, but which is, well, who does that treatment, right? You're talking about 4 medications and building doses of each of those. Who gives it? Do they all come to the heart function clinic? I wish, but we can't. There's no way you can. You have no capacity, right? The wait time will be enormous. Then it has to be a partnership. So primary care physicians can make the diagnosis, right? Make the diagnosis and initiate some treatment, and then identify the red flags, identify the patients that will decompensate, and send them to the heart function clinic. And now we take them over and we optimize them. And so it becomes a shared care as opposed to one group just doing all.
Yeah, so you speak to this multimodal kind of pharmacological approach. What is your typical, cocktail of medications that you like to start with? Like, what's your first medication that comes to mind? Like high yield, right?
Yeah.
There is a patient compliance aspect, right, that you need to kind of mitigate. I know from like our practice that people don't like to take their diuretics very much.
Yeah.
So what would be your typical approach with that?
Yeah, no. So that's a good question, right? Now, the fundamental piece about treating heart failure is that you really want to know what kind of heart failure you are dealing with. And so heart failure with reduced ejection fraction, where their pumping function is poor, and then they really should be on the 4, we call it pillars of therapy. And then we get nerdy a bit, so we call it the Fantastic Four. And so these 4 pillars are, you start with a we call a class of medication called ARNI. That's the sacubitril valsartan. And the second class of medication is the beta blocker, slows the heart down, helps the heart heal and recover. Third class of medication called the SGLT2 inhibitor. SGLT2 inhibitor, those are the sodium glucose transport inhibitors. And that's examples are empagliflozin or dapagliflozin. And the final one is MRA. MRA, that's a mineralocorticoid receptor antagonist. Now, your question is a good one, is that, well, the more you add, the less patient compliant will it be. Well, what are you doing? Maybe just give 2 and hope for the best. Well, no, some patients may improve their quality of life, their functional capacity, and they become more motivated to take their drugs. Okay. So we have been successful at achieving therapeutic doses of all of these medications in patients that do continue them. It's just important to explain what each drug you're doing. And most importantly, what are the potential side effects, right? Just so that if they develop some of these side effects, they don't throw it away and say, hey, I don't react very well. But no, beta blockers, a lot of patients will feel fatigued and tired and sleepy, and they'll feel that they become sometimes even less able to do their exercises, their activities, and they'll think that they're not reacting well. So I explain to the patient, well, imagine you hurt your arm playing tennis. You're not going to play next day, right? You have to stop. You have to rest your arm. We can't stop your heart to recover, but we can slow it, right? So this pill will slow the heart down. Now, initially, when the heart is slower, you have less blood being pumped to your, your muscles, your brain. So you may feel tired, you may feel fatigued, sleepy, less able to access. But over time, each beat, you beat less times per minute, but each beat is more efficient, more effective. So you will recover that energy, that capacity. You just have to give it time. So this is expected. This will happen for most people. Just have to push through it, and then. And before you stop any of these medications, give us a call. Give us a call. We can do things, right? Some of these medications we can switch, make it at night. Sometimes you can rearrange the timing of the other medications. If we give the, let's say the SGLT2 inhibitors, they have some diuretic effect. The patients are like, well, I used to wake up 2 times. Now I'm waking up 5 times at night. How is that helpful? Well, then, you try to put it earlier in the day. Sometimes you cut their own loop diuretic, like the Lasix or furosemide. And so there are strategies that we can do to help those patients. And the best person who does these strategies are the NPs, the nurse practitioner. It means something to when you do one thing in your life. Like, I mean, many of them have broad training, but now they do heart failure. They do heart failure. You ask them about your toe or your eyes, like, no, they just do heart failure. And so they have developed this sort of algorithms of, if the patient has these symptoms, I'll do this. And so we have the capacity to coach the patients and to help them to work with tolerating these medications. And many of them, after the few weeks of adjustment, it just becomes part of it. You wake up, you brush your teeth, you take your pills.
It's so funny thinking about all that and just seeing how complicated it is for each individual patient. Because you think if you don't explain that to them thoroughly, it's like, I feel terrible. It's a beta blocker. And I'm like, the cure is worse than the disease. So I can put myself through this. It's like, no, we have strategies for this. And you can see all the hard work behind the scenes. It's like, oh, okay, we'll change the dose to nighttime. Right. But then it leads to maybe you're up in the night urinating a little more, which ruins your quality of life a little more. So I love this multidisciplinary approach and just overall, I'm going to change how I can to optimize your life and improve your outcomes.
Exactly. And I used to get mad when the patients say, well, no, I don't want this drug. And then I feel like, how could he not want it? That's not right. Like, did he not hate the stats? Like, it's but now, I think I've transitioned to a sort of more patient-centered, like what is really most important to them, right? There's nothing personal here. It's nothing about me. It's about what they need, right? What they need and what they care most about. And if really what they care most about is, I feel better, I'm very active and I feel too dizzy, I can't do all the weights that I used to do, then that's fine, right? So we have to also ground ourselves. We have a cocktail recipe, but it doesn't work for everyone. And you just have to adjust.
Because I'm just thinking, imagine if a primary care physician's so busy, 5 minutes to explain something like, why aren't you taking your meds? Or it makes me feel awful. And if you're out of time and all the system budgets behind it's like, I don't have time to explain this to you and change it a bunch. But you can see why there's a low compliance just from the system deficiencies that people are constrained to working. But then you can see how passionate you are and motivated you are. It's like, okay, this isn't personal. But I'm going to change it for you because this is your life, your medications. So I need to make sure you're on them.
Yes. And I have a few close colleagues who work in primary care. And so one of them, Kevin Laughlin, his word is, when patients come to see us, they're not there to say, hey, what am I missing for heart failure treatment and for COPD, right? They come in, they have an agenda. Like they have, I don't know, the back hurts or this toe or maybe. So it is hard to address their own agenda because they came in the morning really wanting to talk about the back. You have to address the back. There's no question there. And then you try to slide in a little bit of, hey, take this Lasix for heart failure and take this puffer for COPD. And so it is hard. It is very difficult. I think working in a collaborative model where you can offload some of the elements of optimization of care to supportive healthcare professionals, like, for cardiac rehabilitation, for example. If you don't have, as a primary care provider, you don't have to be providing, 5-10 minutes about how to exercise and diet and all of this. No, just refer to cardiac rehab. That's now they take over. And so same thing with vaccination, same thing. So it is possible that your role as a primary care provider is that, you're the quarterback, right? You're sort of coordinating everything for your patient, but you don't have to do it yourself. You don't have to do it for yourself.
Not siloed anymore. No, exactly. It's very much that hub and spoke model where the primary care providers, the hub, and they can refer to all these specialties, right?
Right.
So that's amazing.
This channel and its content are created independently and not affiliated with or endorsed by any employer, agency, or organization. The information provided is for educational purposes only and should not be considered medical advice. Viewers must follow their local paramedic guidelines, clinical standards, and applicable laws when providing patient care. Always practice within your scope of practice and seek direction from authorized medical oversight when required.